those MCQs. Okay. All right. Just a minute. Yeah. The very first question is a psychiatry question. All right. Okay. I'm not taking in much of biostatistics because you know my knowledge in biostatistics, and most of you will know how awful I'm in biostatistics. Okay. Biostatistics, I'll try to arrange a free session for you all through somebody else. So, other questions we are going to see. 24-year-old female, very first person, presented with the 18-month history of asymmetrical weakness of arms with tingling, paresthesia on the right leg. She has decreased visual acuity, altered taste sensation. She has multiple visits to the neurology clinic and multiple tests performed, including MRI scan of brain, CSF examination. Everything is normal. What is it called? A, B, C, D, and E. A will be an option only if you are finding a sudden change, a sudden newly appearing, an acute motor presentation. So A is ruled out because it is an 18-month complaint. Delusional disorder, it's not that, it's not a depression. There is nothing suggestive of depression here. Depression will not have other complaints. It's not generalized anxiety disorder. The only answer here will fit is E, illness anxiety disorder. Very common thing. Frequently, this has been asked in MRCP-1. Okay, this is an illness anxiety disorder where you will get a patient who will have multiple myriad of physical complaints: headache, trouble in vision, constipation, tingling, numbness, itch, joint pain. Won't even know, multiple visits from multiple doctors. This is an illness, anxiety disorder. Okay. All right. Next question. 25-year-old male presented with bilateral painful ankles and red painful nodules on shins. Okay. There may be spelling errors and typo. I want all of you to just adjust with that because these are straight from the candidates. Okay. So hemoglobin 13, ESR, leave it. So before we go to the option, can you tell me what is the diagnosis? Okay, red painful nodules on shins. If this is your shin, you're finding red painful nodules. But the X-ray is normal. What is it called? What is a red painful nodule on shin? What it could be? Excellent. Erythema nodosum, because we have worked out all the MCQs before. So what is the outcome? Is it going to turn into bilateral sacroiliitis or renal failure, IBD, erosive sacroiliitis, or it's going to be okay? Excellent. The answer is E, spontaneous resolution of the symptoms. This is erythema nodosum. There are a lot of causes. Just remember some drugs: sulfonamides, estrogen, OCPs, your strep, TB, coccidiomycosis, histoplasmosis, huge list. Sarcoidosis is very important. We had a Pace's case like that. An inflammatory bowel disease, Behçet's disease, pregnancy, malignancy, leukemia, lymphoma, everything can cause. Just you wait and watch. All right. Next question. We had only 3 options: itching, jaundice, no alcoholic history, and bilirubin is up. So whenever a liver enzyme like a bilirubin or anything is up, plus itching and plus jaundice is seen, what do you think of? Why there is an itch? First tell me why there is an itch. To people who don't know why there is an itch, can anyone answer me in the chat box why there is an itch? Why there is an itch? Yes, cholestasis, everybody knows, but why there is an itch in cholestasis? Why there is itch? Have you seen people with primary biliary cholangitis, biliary cirrhosis, however you call, they'll have a lot of scratch marks because of the buildup of the bile acids. Okay, bile acids, bile salts. this bile will deposit and it cause skin irritation, and this will cause itching. So this is a cholestatic jaundice. Your bile salts, your bile acids all goes and gets deposited, leading to itch. Okay, and also cholestatic jaundice, what will happen? How do you differentiate a cholestatic and a hepatocellular jaundice? Both will have jaundice. Here in cholestatic jaundice, ALP, alkaline phosphatase, GGT, all will go up where it will be normal here. Here PT will be normal, albumin will be normal, here it will be high. This typically will have a benign course, but hepatocellular mortality will be more because most fulminant liver failure or hepatocellular. Now we had only two options for this question: headache, diplopia, papilledema, tinnitus, abductor palsy. So they are talking about lateral rectus palsy. High BMI. What is the diagnosis? You don't need options to diagnose this, right? You don't need much options to diagnose this. This is something you should be able to diagnose just like that. This is a case of idiopathic intracranial hypertension. Absolutely. How patient will present? Headache, blurring of vision. Classically, they will present with something called transient visual obscurations. What are transient visual obscurations? The patient will be normal, and all of a sudden, 30 seconds, vision will completely go off. They'll be like, oh my God, I'm going blind. Then again, vision will be retained. This phenomenon is called transient visual obscurations. All right. Can you guys tell me the drugs causing idiopathic intracranial hypertension? Just two drugs. Two drugs. Type in the chat box. Two drugs causing idiopathic intracranial hypertension. Tetracycline, OCP, and retinoids. Fantastic. Steroids. A lot of list. It's not vestibular schwannoma, somebody said. Vestibular schwannoma can produce a CP angle-like picture, but not headache and papilledema. All right, this is an idiopathic intracranial hypertension. What we will find in the testing, visual field testing, blind spot will be enlarged and dilated fundus will show papilledema. And typical, the recent one, if they ask which is the most specific test, is MRI, which will show transverse sinus stenosis, the most specific of everything, more than your LP or anything. MRI will classically show transverse sinus stenosis. It's happened one and only in case of a idiopathic intracranial hypertension. Also empty cella you can see. Next question. All right, let's go. 30-year-old man present 2-year history of deafness, cardiomyopathy, diabetes mellitus, ischemic stroke, young stroke. You all should know the causes of young stroke and how to evaluate young stroke. Okay? Stroke is my bread and butter, but still you all should know too. So, what metabolic outcome will be present in a mitochondrial diseases? Okay, all of you keep answering. I'll tell you. I'll give you a minute to answer. I'll give you 1 minute to answer. Ammonia has nothing to do with mitochondria. Ammonia has nothing to do with mitochondria. Homocystinemia is an entirely different entity. It has nothing to do with your mitochondria. Homocystinemia has nothing to do with that. What will happen? Mitochondrial disease, lactic acidosis, lactic acid buildup will be there. That is a classical feature of mitochondrial disease, not your hyperammonemia, not your homocystinemia. It's lactic acid buildup. All right. Okay. What are the mitochondrial markers? Lactate. All of you note down. All of you note it down, please. Creatinine kinase, pyruvate, organic acid, amino acid, carnitine, oxidative stress markers, circulating cytokines, all are mitochondrial markers. And your homework is I want all of you to go and study what is called a mitochondrial cocktail. That's the homework for this question. Right? Next, a woman presented with painful ulcer on lateral midcalf. Deep ulcer is there with indurated margins and erythema. There's a history of trauma, there is an undermining age, and it's a rapidly growing ulcer. What is it? You should start learning to rule out things. Will a trauma cause a rapidly growing ulcer? No. Is it necrobiosis lipodica diabeticorum? No. Why? This is a waxy lesion, yellowish, crusty, waxy lesion. Is it an arterial ulcer? Absolutely not. There should be some vasculopathic features there. Nothing. Is it venous ulcer? It won't suddenly grow off all of a sudden. Rapidly growing ulcer. Undermining edge. Rapidly growing, undermining edge. Indurated margin points to your pyoderma gangrenous. All right. Okay. Next question. Let's go and see. 46-year-old man with 3-week history of progressive weakness, headache, 6-year history of uncontrollable hypertension. He's taking ramipril, bisoprolol, amlodipine, doxazosin, atorvastatin, so many drugs. There is hypokalemia. USG is normal. Hypertension with hypokalemia. Which one? Hypertension with hypokalemia. You can rule this out. Gitelman won't cause that. You can rule this out. Again, it won't cause that. There is no other feature suggesting of pheochromocytoma. You can rule this out. It won't cause hypokalemia. There is no Cushing's in the options here. So what you will think? Kidney disease, it's a very vague option. Okay, kidney disease, mostly there will be increased potassium buildup. So what is the answer here? Excellent. It's hyperaldosteronism. All right. This is the difference between these 3 important syndromes, Gitelman, Bartter, and Little's. All of you listen very carefully. Gitelman and Bartter are autosomal recessive. Note down, note down, note down. Very important. Basic sciences they will ask. Little's autosomal dominant. Got it? Which 2 are autosomal recessive? Gitelman and Bartter are. Next point, age at presentation. It presents at the late childhood to adulthood. The Bartter will be neonatal infancy and Little's also childhood. This is the most important thing you have to note out. Gitelman will show hypochloremic, hypokalemic alkalosis. Hypokalemic, hypochloremic alkalosis. Same for Bartter. But Little's will show hypernatremic, hypokalemic alkalosis. Next, there will be increased renin-aldosterone ratio in Bartter and Gitelman, where it will be decreased in Little's. All right. Urine analysis will show low calcium in Gitelman, high calcium in Bartter, and normal calcium in Little's. So how do you treat? Here you will use potassium-sparing diuretics, Bartter prostaglandin synthetase inhibitor, and here you will go for amiloride because patient will present with hypertension. All right. Very, very important slide. So many MCQs has been asked. So be very clear. Yes, now let's come to our neurology. Fascinating. Okay. What the question is, 58-year-old woman presents with 3-week progressive history of pain, weakness, clumsiness of the right hand. On examination, there is weakness of abductor pollicis brevis and opponent's pollicis. Decreased sensation of the palm and lateral 3.5 fingers. Should be lateral 3.5 fingers. What nerve supplies this area? You should know what nerve supplies abductor pollicis brevis and opponent's pollicis. If you tell that, you will know the answer. Let us rule out. Radial nerve palsy will cause what? It will cause wrist drop. So rule it out. Posterior interosseous nerve, no, it will just cause motor symptoms alone because it doesn't have any sensory supply. Ulnar nerve, no, it will be in the medial of that to the little finger and up to the medial side of the ring finger. T1 lesion, it's not. The only answer is median nerve. You know what median nerve supplies? This is the sensory supply of the median nerve. There are two nerves, palmar cutaneous, digital cutaneous branch. This is the palmar cutaneous area in the palm. These are the digital cutaneous branches. All right. The palmar surface, this is the dorsal surface. And carpal tunnel syndrome, the sensation will be spared because the nerve travels above. All right. Got it. Next question. 65-year-old man with diabetes mellitus type 2 on empagliflozin. What is the mechanism of action of empagliflozin? 10 seconds. I want the answer. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Because no point in spending time on this kind of questions. These are very straightforward. Just 10 seconds. You are bound to know. There is no excuse you can tell that I don't know the answer. The answer is D. 35-year-old female, early breast cancer. Sister had ovarian cancer at 39. Grandmother had colon cancer. Grandfather had prostate cancer. Mutation is in straightforward. Straightforward question. Where you will locate the mutation here? Absolutely, the answer is A. It's BRCA1. Now you should know what are the other cancers due to BRCA1. People who made a mistake here, please note it down. BRCA1 and 2 carriers can go for a prostate cancer, breast, gastric, pancreatic, and ovarian. Because MCQ comes, I don't want any one of you to fumble here. All right, be very clear. Note down every point. All right, I hope all of you noted down. So prostate, breast, gastric, pancreatic, and ovarian tumors. Next question. 60-year-old male underwent transsphenoidal pituitary surgery. 10 days after that, he had developed polyuria, increased thirst. Sodium is high, potassium is normal, rise to urea and creatinine. What do you think is going on? What do you think is going on with this gentleman? Absolutely, it could be an SAADH. What would be the sodium levels in SAADH, doctor? Absolutely. Could be cranial DI. Could be posterior pituitary could have been damaged by the surgeons. So what do? You don't do water deprivation test here. The test you have to do immediately. The next test is going to be paired plasma and urine osmolality. So the answer is A. The answer is A. All right. Next question. 45-year-old presented to respiratory clinic, 3-week history of shortness of breath and cough. He is a spray painter in car garage. His symptoms improved outside environment. What is the diagnosis? Straightforward. Somebody is having a symptom, shortness of breath and dry cough or anything like that, only when they are at the work. They are better once they are outside the work. This is a classical presenting feature of an occupational asthma. In UK, we give them something called PFD. What is PFD? It's called peak flow diary. They have to do serial peak flow measurement, enter the values in the diary. They have to get it back to the pulmonologist or respiratory allergy physician, and they will look at that and they will prescribe medication. This is a case of an occupational asthma. 80-year-old women presented with spasticity. These are the anatomy questions that led issues to a lot of people. There is difficulty in flexing distal phalanx. Which muscle flexes the distal phalanx? That's the question. What is the answer? Which muscle flexes your distal phalanx? Which muscle flexes your distal phalanx? That's the question. A, B, C, D, E. Mhm. The answer to this question is A, flexor digitorum profundus. Okay, it's okay to get some questions like that. Okay, it's okay to get some questions like that. Somebody requesting lecture video on WhatsApp group, moderators, they will definitely do. Welcome, doctor, they will do that. They'll send you. Flexor digitorum profundus is the muscle that flexes the distal phalanx. Many neuromuscular neurologists themselves won't know all the anatomy values. It's impossible. Little thing about this muscle today, let us learn. It originates from the proximal three-fourth of the ulna. It then inserts all the way into the distal phalanx of the digits 2 to 5. What it does, it flexes the distal phalanges at distal interphalangeal joints. Innervation, medial part by the ulnar nerve and lateral part by the median nerve. Remember, it has dual nerve supply. It has a dual nerve supply. 56-year-old guy, difficulty walking, frequent falls. Wife reports about him snoring loudly. His blood pressure is 148 on supine and 116 on standing. More than 20 millimeter of mercury difference. This is what we call as orthostatic hypotension. All right. So somebody with an orthostatic hypotension with slow speech, okay, marked rigidity in the trunk and bilateral resting tremors. What is it called? It is not C. Who are telling C? Why it is not C? What happens in progressive supranuclear palsy? That will lead to upgaze restriction and upgaze pulse, and there will be falls. Is he having all those things? No. It's not a cerebral basal degeneration, it's cortico-basal degeneration, it should be. It's not again. On the cortical sensation, higher sensation will be lost. It's not just Parkinson's disease. Parkinson's disease does not cause autonomic nervous system involvement. What happens here? There is an autonomic nervous system involvement. Okay? There is an autonomic nervous system involvement. He has some faults. It's okay. But still, PSP will have upgaze palsy first. This faults this gentleman has, Dr. Harim, is not due to his upgaze restriction. It's due to his orthostatic hypotension. Have you seen long-standing diabetic people? They'll just walk. Suddenly they will tell, I'm feeling dizzy. Just I want to sit down. If fall. This is a different fall. This is not due to the upgaze restriction in progressive supranuclear palsy. This is a case of multi-system atrophy. Unless you get this and this, don't go for PSP. Upgaze palsy is the most specific finding. Also, PSP, the gait will not be like a Parkinsonian gait. Snoring, he can snore for any reason, though. That can be immaterial. These are called red herrings. You know, just to divert you, they will keep all these things. These are called red herrings, snorings and all red herrings. Okay, so falls, this fall is not due to that. Parkinson's disease, sorry, will not present with falls and will not present with autonomic nervous system involvement like orthostatic hypotension. Are you getting, doctor? Parkinson's disease will just have its classical features: bradykinesia, rigidity, and then your postural instability and tremors. Okay? Autonomic nervous system and snoring don't correlate that. That is something that. Okay. Autonomic nervous system dysfunction, what are the classical features? Are your erectile dysfunction. Okay. It can affect your urinary system, leading to some dribbling, post-micturition dribbling, and all the stuffs, hesitancy, urgency, and then it can cause bradycardia, tachycardia, it can cause heart rate variability. Then autonomic nervous system can cause orthostatic hypotension, and autonomic nervous system can cause some some sweating issues, hypohidrosis, and all. Those are the things you should be looking for autonomic nervous. Not the snoring. Oh my God, the system is not recorded till now. Fine. So snoring is not a part of it. Okay. Doctor, I'm repeating everything. Please listen or go back to the recording, doctor. Every question I cannot repeat. We have a lot of things to do. Please pay attention while it is being taught. All right. 24-year-old guy plays trumpets. He presents with sudden onset breathlessness, pleuritic chest pain. X-ray shows right-sided pneumothorax. He has been successfully treated and full re-expansion of the lung. What should he avoid doing? A pneumothorax patient is coming to you. You are completely treating him. He should not do scuba diving. Of course, yes. All of you got it, okay? 30-year-old male presented with unilateral breast swelling. He had undergone breast reduction surgery for contralateral side 10 years back. He has sparse pubic axillary hair, reduction in testicular volume, FSH is high, LH is low, testosterone is low, prolactin is high. Without seeing options, can you all tell me what could be the probable diagnosis? Kalman, is there anything that's suggestive of anosmia? If they are not mentioning anosmia, little keep Kalman out of the way. Prolactinoma. Prolactinoma can cause breast leakage, but it won't all of a sudden cause a gynecomastia. This guy had a gynecomastia for quite a long time. And prolactinoma will also cause other compressive symptoms. If it is going to be this much breast swelling, like male gynecomastia, there will be other compressive symptoms will be there, other milk leakage, everything will be there. Okay. This is a case of straightforward Klinefelter syndrome. No anosmia, so it is not that. Not hemochromatosis, no other features of altered LFT, diabetes mellitus, pigmentation, nothing is there. It's not craniopharyngioma, it's not a prolactinoma either. This is a Klinefelter syndrome. All right. Next question. 30-year-old male presents with spots over the beard. He is a known case of HIV, not an antiretroviral. Umbilicated lesions over the beard. What are this called? Lesions with central umbilication, typically in immunocompromised individuals. Straightforward, no time wasting with this kind of questions. Molluscum contagiosum. That's it. Done. All right. Next question. Muscle for plantar flexion. Come on. Anatomy. Lot of anatomy this time. There are three muscles, actually, three muscle groups. What are they? One is gastrocnemius, another is plantaris, another one is soleus. Boring, right? We are back to anatomy. There is nothing we can do. Okay? There is nothing we can do. It's a combination of something they call as triceps surae. I'm not going to go into in depth of all those things. All right. And do you know what other important thing about soleus? Anyone know what soleus is called as? Mm-hmm. It's very important in pumping the venous. Excellent, Dr. Mujtaba. Yes. Acts as a pump. It's a peripheral heart. Okay. From down your leg, venous supply goes up, venous return goes up because of the active muscle pumping of the soleus. Okay. So diabetic people, we have done a study, people who are sitting for quite a long time, suppose like many consultants here are diabetic. Okay. So some consultant is sitting for a long time and seeing cases. If he keeps activating soleus pump, like he's keep on doing some pedaling movement all the time, again and again, over and over, that will activate the soleus pump. Okay, and that will decrease some amount of blood sugar levels also by upping the metabolism. Man with 3 week history of fatigue, headache, uncontrolled hypertension for 2 years, an antihypertensive drug is given, and BP is 160 by 96. There is hypoglycemia and suprarenal gland thickening. What is the diagnosis? Correlate everything and you will get the diagnosis. Absolutely. The answer is Con syndrome. Why? So many times I told you hypokalemia with hypertension. Pheochromocytoma. Yes, fancy diagnosis, but other features of pheochromocytoma should be present. Not that. Non-compliance, no. Adrenal hyperplasia, not the answer. It's the Con syndrome. Hypokalemia with hypertension. Remember. Next question. All right. 55-year-old male presents with complaints of difficulty in walking, weakness in the upper arms. Developed over 3 hours. On examination, upper arms, there was weakness with reduction in the tendon reflexes. On examination of the lower limbs, there was weakness of hip flexion with increased tone, brisk tendon reflexes, extensor plantar. First, stop here and tell what is happening in the upper limb and lower limb. Upper limb is having weakness and reduced tendon reflexes. What is that? An element pattern in the upper limb. And the lower limb also has weakness, but increased tone and increased reflexes. So it has a UMN pattern. Plus, go for the sensory. Now, what are the findings you are getting in the sensory? There is a reduced touch and painful sensation, and vibration position, joint position was intact. So what is the diagnosis? Where you will get all these findings? Anterolateral column. Can you all tell me where is the diagnosis? Cervical myelopathy. Who said B? B, you will get something called inverted reflexes. Not reduced tendon reflexes. Inversion of the biceps, inversion of the triceps is what you're going to get in cervical myelopathy. It's not GBS. GBS is pure element. All right. It's not pontine infarct because there is no cranial nerve involvement here. It's not anterior spinal artery occlusion. What happens in anterior spinal artery occlusion? The effect will be more in the lower limb than the upper limb. Upper limb will be nearly normal and span. The answer here is syringomyelia, a classical pattern which I have told you here. Remember, one, upper limb will show LMN weakness. Note it down. Lower limb will have UMN weakness. Note it down. Sensory pattern. Typically, if this is the patient's head, where I can draw, here I will draw. Okay, this is the patient's neck. Okay, it's the back of the neck. Imagine the shoulder. Around this area, there will be sensory loss. Typically. All right, around this area, cap-like distribution, there will be sensory loss. All right, then the other thing that can happen in syringomelia, like I said, upper limb will show LMN and lower limb will show UMN. This sensory loss finding, it can be anterolateral column, but suppose if the syrinx is extending, suppose if it is extending posteriorly, it can also cause, you know, your, it can also involve your posterior column sensations as well. Okay, this is a case of syringomelia. I hope all of you got it. Remember, whatever I have told you, this is how to diagnose it. Again, anatomy question came. Ankle reflex, which nerve root involved? That's the question. Anyone? Straightforward anatomy question. Straightforward anatomy question. Ankle reflex, which nerve? S1. Most specific if they ask, S1. Done. Know it or know it not. This is the table. Okay, it's fine. I'm not going to go through all the table, but you are allowed to take a screenshot or a photo. Take it. Take a photograph of this table if you want. It will help you. All of you taken? I'll wait. Questions are coming from tables like this. It's very tough to remember everything. We are supposed to remember because we are dealing with neurology. But you guys, it may be a little difficult to remember. Just stuck somewhere in your wall room. Okay, it will help you out. These questions, leave it. Community medicine, sorry, this your biostats. Then we can go for the next one. Right. 16-year-old woman, she had a pain in the left cheek since 1 week. She has previously 5 episodes each last for 2 weeks. Lesion happened in the same location every time and resolved spontaneously. Each time it was precipitated with a tingling sensation. Clear cluster of vesicles in erythematous base. There is only one condition here, will show a cluster of vesicles. Same location in the cheek. It's not a zooster. Zooster is something involving more. It's just herpes simplex. Zooster is if it goes to the auditory canal and it involves something else. It's not an impetigo, definitely. It's not pemphigus vulgaris. It won't rupture the bulla. And it's not a pemphigoid. Pemphigoid is a bullous area, bullous lesion. Okay, it's a bulle. This is a herpes simplex. Always remember, cluster, it's always a herpes. Okay, it's not a zooster, it's a simplex. 22-year-old male with macroscopic hematuria. Okay, the macroscopic hematuria. He was in Malawi last year, presented with bladder symptoms. Lake Malawi is known for what? Excellent. Cystosomiasis, cystosoma hematurium. Okay, typically they call it, they call the symptoms as a male menstruation. Why they call it as a male menstruation? They'll have hematuria just like that, blood passing macroscopic. So what is the next thing you are going to do here? Cystoscopy biopsy little later. First, they are asking about the next step. They are not asking about the confirmatory step. They are only asking about the next step. Urine culture. Do you think cystosoma will grow out of the culture, doctor? Will cystosoma hematobium will grow out of any culture? Absolutely not. You won't do anything with the stool. Cystoscopy later, end micturition urine sample is what you have to do. All right, they're asking next step. Polymorphism of which of the following will affect warfarin? This is a know it or know it not question. If you know it, you will answer. If you don't know, you won't answer. Straightforward. I have already taught this thing in clinical pharmacology sessions of mine. For the next batch, we have an official clinical pharmacologist from NHS who will be teaching you. A, B, C, D, no D, no E. Only three options they had asked in the last paper. The answer is CYP2C9. All right, CYP2C9. Go back to my clinical pharmacology lecture. I had covered this. All right, I had covered this. Next question, 19-year-old woman was having a fever, night sweats, and enlarged lymph node. Chest x-ray showed a mediastinal mass. Blood count is normal, LDH is elevated. So a chest x-ray showing a mediastinal mass, there are B symptoms suggestive of night sweats, enlarged lymph nodes. What exactly you are going to do next if the patient is right in front of you in your clinic? Any doubt? No, absolutely straightforward excision biopsy of the lymph nodes. Excision biopsy of the lymph nodes. 65-year-old man with left-sided Horner syndrome, dysarthria, dysphagia, right lower limb hemiparesis with nystagmus. What is the most appropriate diagnosis with all these things? Tell me the diagnosis. Diagnosis is, I asked the diagnosis, LMS. It's Wallenberg syndrome or lateral medullary syndrome. The culprit artery is pica. Other culprit artery is V4 segment of your vertebral artery. So how do you know the site of the lesion? The side of the Horner syndrome is the side. If the Horner syndrome is in the right, if the Horner syndrome is in the right side, then it's a right pica. If the Horner syndrome is on the left side, then it is a left pica. Remember the side of the Horner syndrome. All right, side of the Horner syndrome. Next question, 10 seconds. I want all of you to answer. Mechanism of action of dabigatran. Right. I don't think you should require more than 10 seconds. 10 seconds. Mechanism of action of dabigatran. Is my audio audible? Hello, everyone. Can you all hear me? Am I audible? Yes. Okay. Dabigatran, D for D, it's a DTI, direct thrombin inhibitor. Okay. All right. 75-year-old male with diplopia. On examination, no adduction of the left eye. Right eye shows nystagmus. So just draw here, I'll explain you what is it. These are two different eyes. I'm sorry for asymmetrical eyes, left eye and the right eye. In the left eye, there is no adduction. Adduction deficit is there in the left eye. On the right eye, there is nystagmus. What is it called? This is called internuclear ophthalmoplegia. So, where is the lesion? It is in medial longitudinal fasciculus. I hope all of you know sixth nerve and third nerve are connected by that. So, which MLF, if they ask you, what will be your answer? Right MLF or left MLF? Is it right MLF or left MLF? Excellent. It is a left side. The side of the adduction deficit is the side of the lesion. So it is a left-sided MLF. Old male with high BP and found to have coarctation of iota. Okay, it is associated with which of the following? Young coarctation of iota, most common cause. Please don't think and imagine some rarest of rare causes which is completely non-existent. The answer is D, bicuspid aortic valve. The answer is D, that is your bicuspid aortic valve. All right. 69-year-old lady with TIA, history of recurrent UTI, USG shows a right kidney of 8.5, left kidney 7. There is BP is high, carotid proteinuria, creatinine is up. What is going on? Any idea? It's not atheromatoous renovascular disease. There is no other options are there. Something that is very peculiar here is the recurrent UTI. It is not a feature of atheromatoous renovascular disease. That can atheromatoous renovascular disease or your amyloidosis, amyloid diabetic nephropathy, all this can end up into acute kidney injury and progressive CKD, but not recurrent UTI. Somebody is presenting with recurrent UTI, always think of, yes, Dr. Kirsan, yes, Dr. Sana, everyone answered. You have to think of pyelonephritis. Amyloidosis, very rare. The kidney that is going to get affected frequently, initially enlarged, later it will shrink. That's why asymmetry, because it's a chronic condition. Initially, as soon as the pus gets collected, the water gets returned to the kidney will be swollen up, swelled with pus, everything, and later, as soon as all the parts of the kidney starts dying. Right? Next question. 20-year-old male presented with 2-day history of painful eye. He has ankylosing spondylitis. Visual acuity is right eye is red with hypopyon and irregular pupil. What is it called? In an ankylosing spondylitis patient, he's coming to your clinic. Doctor, I'm having painful eyes, doctor. My eyes are too painful, doctor. Please help me, doctor. What exactly is that? No options for you. All of you should answer without option. Excellent. Cells in the anterior chamber with that. This is an anterior uveitis. Right? Next question. 65-year-old man presents with 12-month history of pain, pins and needle sensation in both the lower limb, diabetes, the decreased ankle reflex, pain sensation decreased till knees, and vibration is absent at ankles. This is a case of, what is the diagnosis? What is the diagnosis? Diabetic patient, what? What? Oh my God, a lot of people talking about B12 deficiency. Listen to me well. I'll tell you something. Listen to me well. Autoimmune neuropathy, B12, subacute combined degeneration. How it presents, I'll tell you. Listen to me. This will present with absent ankle jerk plus extensor plantar. Rhombex will be positive. So you need to know all this finding together. Is it there? Anywhere it is there? No. This is a case of diabetic neuropathy, nothing else. What is the first sensation that will go off here? In diabetic neuropathy, it's the vibration. Okay, this is a case of diabetic neuropathy. What will you give? What is the first choice? Up to date says it. What is the first choice? What is the first choice? Absolutely, gabapentinoids. The answer is D. 20-year-old male with type 1 diabetes was screened for celiac disease. What process HLA is HLA dependent? ABCD. I told you in my basic sciences lecture, no point in anyone making any mistake. I don't want any one of you here to make any kind of mistake. What I am asking, what process is HLA dependent? Tissue transglutaminase binding is HLA dependent? Really? No. What does HLA do? They are going to this option because it's related to celiac disease, but they are not bothered about celiac disease. They are asking only about what does HLA do. Please read the question. They are only asking what does HLA do. HLA does, it's an antigen presenting cell. What is the difference between HLA-A and B? Sorry, HLA and type 1 and type 2. Everything has been told in the free lectures. Please go back and watch. Next question, 45-year-old male presents with 1 year history of snoring and refreshing sleep, daytime sleepiness, increased BMI. No previous history of apneic episodes. Epworth sleepiness score is 13. What is the diagnosis? First, morning time, gentleman is fully asleep. Morning time, gentleman is fully asleep. Excellent. This is OSAS. So what will you do? Symptomatic improvement. What is the best intervention? Uh-huh. I'll tell you, whenever in PACES exam, if they are asking you something, just listen to me. They're asking you, how do you manage this gentleman, doctor? We go around telling, I'll give him CPAP, I'll give him NIV, I'll just do a uvulopalatoplasty, I'll do a mandibular, I'll put a mandibular advancement device, and I'm giving modafinil, modafinil. They'll be very upset with you in UK. Any patient management in UK always starts three things. That is patient education, patient counseling, and multidisciplinary team management. If you want to see a good symptomatic improvement in this guy, decreased BMI is must, not the other thing. Modafinil will only keep him from sleeping in the morning time, but it's not going to improve his other symptoms. The answer is weight reduction. All right, then comes all the other things. Weight reduction is the key here. Your CPAP, uvulopalatoplasty, mandibular advancement device, modafinil, modafinil, or nothing. All right. The moment he starts losing weight, he will feel symptomatically improved. Okay. One more question, then we are going to have a break. Gram positive cocci in clusters. B. What if BiPAP and CPAP is as CPAP? Definitive management, again here weight loss. Nothing will help in a high BMI. If it is due to something else, VOSAS can be due component of thyroid, of acromegaly. In those cases, you have to treat the underlying cause. Definitive management for anything is the treatment of the underlying cause. So here it's Staph aureus. CPAP, you start weight reduction, he's not improving. You give some sleep hygiene measures, not improving. He's having frequent apneic spells. Nighttime, he's waking up like that, he's coming up. Then you have to go for CPAP. If you see this question here, no previous history of apneic spells, weight reduction, got it? All right. So you use CPAP when the first line managements are failing, and never before you start a first line management. Okay. All right. Let's take a break here. I'll need a 10 minutes break. I'll be back. Okay. We'll start because we have a lot of slides to cover. We need a break for our mind to process as well. At 5 to 10 minutes break. Hello, I'm back. How many of you are here? I'm not sure whether 10 minutes or 5 minutes is over. I'm just back because we have a lot of things to discuss now. Okay, welcome, doctors. Welcome back. Welcome back. So, which drug will cause hyperglycemia? That's the question. Straightforward. Okay, which drug will cause hyperglycemia? Yes, absolutely. Indapamide and statin to some extent. But the best option will be indapamide. There is no doubt in that. Okay. There is no doubt in that. It's thiazide diuretic. You should know the other adverse effect of thiazide diuretics. You should know what are the contraindications of thiazide diuretic. What are the other adverse effect of thiazide diuretic? Each one type 1. Excellent. Gout, weakness, muscle cramp, hypercalcemia, pancreatitis, hyperlipidemia. Beautiful. Yes. You know everything in fingertip, then no worries. What is the which cell secretes surfactant? There is no options was given. It's fine. You can tell without seeing any options. Which cell secretes surfactants? It's type 2 pneumocytes. Right? Type 2 pneumocytes are otherwise known as type 2 alveolar cells. Both are one and the same. Okay, please don't get confused. Pneumocyte, both are one and the same. When you will give IG, immunoglobulin, when would you immunoglobulin? And when will you give vaccine? Patient who had renal replacement therapy previously now allocated for renal transplantation is found to be negative for varicella zoster immunoglobulin. So somebody undergoing a renal replacement therapy, now he is set for renal transplant. When you will give immunoglobulin? Yes, you give immunoglobulin 4 weeks prior to transplantation. All right. And vaccination 4 weeks again prior to transplantation. All right. Okay. Somebody with cognition impairment and a history of frequent falls. He's on citalopram, tetrabenazine, zopiclone, and procyclidine, finasteride. He developed akinetic rigidity and paucity of the movement. Which of the drugs above can cause akinetic rigidity? The above drugs will cause an akinetic rigidity. Any idea? The options are the above drugs. Excellent. It is your tetrabenazine. Tetrabenazine is notorious to cause akinetic rigid syndrome. 45-year-old with 4-month history of progressive deterioration of the vision in right eye. Right eye visual acuity is lost. He has a history of neurofibromatosis type 1. What is the common complication, ocular complication of the neurofibromatosis type 1 that can lead to a visual loss? ABCDE, straightforward. Neurofibromatosis is associated with optic nerve glioma. This optic nerve glioma, choroid hemangioma, and Stooge-Weber syndrome and other things, not the neurofibromatosis. NF1, most commonly ocular, it will cause optic nerve glioma. This will lead to decreased visual acuity. It will be progressive. It's not some sudden visual loss, a progressive loss. 25-year-old drug abuser with injection site abscess has pansystolic murmur. So what is the best drug? So IV drug abuser, endocarditis, right? That's the diagnosis. What's the best drug you will give? IV drug abuser, endocarditis, what is the best drug you will give? I'm not going to stop here and teach you the entire infective endocarditis treatment regimen. That certainly we will do some other time. The answer here is going to be your fluoxetine. Excellent. Everyone got it. Beautiful. All are prepared. 45-year-old patient with a duodenal ulcer managed with proton pump inhibitor-based triple therapy. So what test you will do to determine H. pylori eradication? You want to know whether H. pylori is still there or it's gone. It's still there or it's gone. Which test will tell you whether the H. pylori is still there or H. pylori is cleared? One test. Only one test. Excellent. It's urea breath test. All right. It's urea breath test is the best investigation to determine the eradication. 54-year-old man, blah, blah. Question 10 seconds. Mechanism of action of imatinib. That's it. What is it? Straightforward question. 10-second answer. Tyrosine kinase inhibitor. That's it. Done. A patient was found on road with convulsion. There is dilated pupils. Pulse rate is 120, BP is 180. What could have caused tachycardia with hypertension, convulsion on the roadside? Which drug would have caused all these things? Adding to this, he may be even having a chest pain. Oh my God, my chest hurts so much. What is it? Which drug? Obviously, your cocaine is notorious to cause all this thing, right? Cocaine is the answer. Patient with limited systemic sclerosis, the antibody, the answer itself given is centromere. Diffuse is what antibody? ACL70, good. Centromere is limited cutaneous sclerosis. A young girl with low intellectual level, agitated presence with perianal itching at night. Straightforward question. Perianal itching at night. The answer is it's a pinworm, right? Perianal itching. Always remember, pinworm is the most notorious cause of that. What is a pinworm? What is called a pinworm? Entropy is most common cause. All right, most common cause. Perianal itching. Remember always P for P. Perianal pinworm. Pinworm is Enterobius vermicularis. Answer is B. Young gentleman. Okay, an young gentleman is there. Family history of positive Becker's, Duchenne's dystrophy, is concerned that he might have the disease. So what next test you will do? It's a very straightforward question. No excuse in making any mistakes here. You don't do a muscle biopsy. No, you don't just ignore because a lot of things depends on that, right? EMG is not going to show you anything. This is dystrophin gene analysis will give a clue. If positive, you have to be careful. All right. Patient admitted with pneumonia afterward developed weakness of extension of fingers. Which nerve causes extension of fingers? Which nerve is responsible for extension of fingers? You know the nerve name? Then you will know the answer. Which nerve will cause extensor? Which is the primary extensor nerve in your upper limb? Which is the primary extensor nerve in the upper limb? Which nerve supplies the extensor muscles? What is that nerve called? Absolutely, radial nerve. The branch of radial nerve here is your posterior interosseous nerve. Okay, we all heard of pin palsy? It's a pure motor palsy. No sensory deficit corresponding to the radial nerve distribution will be here. Middle-aged man. The 3-week history of shortness of breath, PO2 is reduced. What he will think of? Middle-aged man, PO2 reduced, most common cause, not the hyperventilation. Here, the thing you have to think about is a pulmonary thromboembolism, not the hyperventilation. 3 weeks history of shortness of breath will not be there in hyperventilation because he is not going to hyperventilate for 3 weeks time. All right. Next, only 2 options we are given. Severe LV failure. What is the most important predictive features? Severe LV failure. S4 can be there. Is it specific? Is S4 specific or pulsus alternans is more specific? Excellent. Yes, the answer is B, pulsus alternans. A rapidly alternating pulse. How it will be? You're going to go and palpate the patient. One beat will be tup, tup, like that. That's pulsus alternans. Hayflick limit. Answer is the only option. It's telomere shortening. What is Hayflick limit? Amount of time a chromosome can divide and all these things is limited by something called Hayflick limiting. Okay, this determines the telomere shortening, lengthening, everything. That's called Hayflick limit. All right, what enzyme is responsible for metabolism of isonic acid? If you know it, you will answer. If you don't know it, you won't answer. When I don't know the answer, till I went through the MCQs once. Excellent, Dr. Dakshayani. The answer is straightforward. It's called NAT2. That is N-acetyl transferase 2. That's why we thought all these things way back in our clinical pharmacology sessions. Which enzyme is responsible for what? Everything. The reason we have thought all these things because we were expecting such nightmares happen in the examination, and such nightmares absolutely happened. Without anything, these nightmares came to a reality. Clinical pharmacology question. No, don't read all these things. You read past medicine notes and sleep and wake up, you will pass with full marks. It doesn't work with everyone. 1 to people with superior knowledge in general medicine, they will easily pass and go. Not everyone. Okay. Cavernous sinus thrombosis through which vein together with facial vein infection spreads? Cavernous sinus, this is your skull, it's your face, the eyes. From where it spreads? From where it spreads? Come on, doctors, answer. When drew here a picture, and I even told you this is your eye, this is where your cavernous sinus is there. From where to where it can go? Inferior ophthalmic vein will be here. Will it go through this? This will be inferior palpebral vein. Will it go through this? Which will reach this place fast? Simple, logical question. This is your option A. This is your option B. This is your option C. You want to go to this destination. Which will reach fast? You will go all the way from here to there, or you will go all the way from here to there, or you will all the way go from here to there. This is your superior ophthalmic vein. The answer is A. Okay. Together with facial vein is the anatomy of cavernous sinus. Extremely important. This is the cavernous sinus area. This is your pituitary gland. This is optic chiasm. There is an internal carotid artery. This cranial nerve 4, cranial nerve 5, 2, your abducens nerve, your oculomotor nerve. All these are a part of cavernous sinus. All right. You don't need to remember everything, doctor. 1 or 2 questions will be coming like that, Dr. Sana. You don't need to remember entire thing. No need to remember entire thing. 1 or 2 things, it's enough. You don't need to know everything. Okay. I'm in touch with some anatomists. We got a person for clinical pharmacologist, a specialist. All right. So I'm in touch with an anatomist also. If there is any possibility, we can. Thing is, we are all into clinical medicine for a long time. I'm into now completely into neurology. And ID, I rarely practice. General medicine, yes, because there are not great registrars around. Yes, we do. Okay. Just excuse me for 1 minute. Yeah, hello. I'm so sorry for the interruption here. Catechol, what antibiotic you will give? Straightforward. This is like a know it or know it not question. Moraxilla catechol, what antibiotic you gonna give? All of you can hear me? No, not piperacillin. Asian side, that's what happening in India. I'm seeing everything, every patient coming, they're receiving this piptas straight away. Because why? There is a heavy antimicrobial resistance. The clinic, everyone is dispensing drugs. Your general practitioner, all this, this Ayush practitioners dispensing the drugs. Clinical, this not clinical, I mean this pharmaceuticals, they are dispensing the drugs. And then meropenem only. That's true in coming to here. But in UK, what you will give? UK, you don't go for piperacillin, meropenem and all. To get approval for this drug, ID team will come, they will question, why? Why you want to give him piperacillin? You found any antimicrobial resistance? What's the first line drug you're going to give him? Moraxilla catechol. What do you think is the first line drug? Leave our practice in other countries. Think in UK what you will do, where the antibiotic resistance is relatively fine enough. Among A, B, C, what you will give? It's A. Start an amoxicillin and see how it goes. All right. Of course, here in Asian countries, you have to go for a PIP test. There the situation is different. Upper esophageal vein, varices drains into where? Somebody asked about venous drainage. All right, fine. Upper esophageal varices. See, esophagus, if you take upper, middle, lower. or you can call as a proximal and distal esophagus. This proximal esophagus vein drains into which venous system? Of course, it's azygos vein. Excellent. This is the venous drainage of esophagus. Some important venous drainage, it's okay to know. All right. So proximal and distal azygos. The mid esophagus to left gastric vein. Okay. Just remember, proximal and distal goes to azygos and mid esophagus goes to collaterals of the left gastric vein. 18-year-old female collapsed at home. History of opioid addiction handled with methadone. What is the most likely cause of her death? Opioid addiction. What can opioid do? Collapse, death. It prolongs the QT interval. Last question is upper esophageal veins drains where, doctor? Please pay attention here. Okay. Esophagus has three parts of drainage: upper, mid, and lower. Upper goes to your azygos vein. The mid part will go to your gastric vein. All right. Now come to this question. Opioid. See, this opioid addict suddenly dies. It's due to prolongation of the QT interval. You'll go for an arrest. So you should know the type of long QT syndrome. Otherwise, genetic ones, Romanov ward, autosomal dominant, Jarvell-Lange-Nielsen, autosomal recessive with some hearing loss. And there is some Anderson syndrome, Timothy syndrome, all the stuff. Okay. These are the different. Actually, the first 1 and 2 are due to potassium channel defect. 3 is due to sodium channel defect. They had asked one sleep. Everything involves sleep. Exercise. 1 is most commonly due to exercise. 3 is most commonly due to sleep. 2 is most commonly due to emotional stress. They had asked, that's why you should know. All right. You don't need to know everything in the table, but just at least what I have marked here is something you're supposed to know. Sorry. Embryonal stem cells are protective. Why embryonal stem cells are not destroyed that easily? Stem cell research is a big market. Okay, they're asking why embryonal stem cells are protected. Why and how? Excellent. The answer is B. Is there any lack of oxidative stress? Is there any oxidative stress in embryonal cells? Absolutely not. It's protected. Once the embryo grows, becomes a baby, comes out to this present world, in every part, in every way, stress, and more stress. That leads to this. Okay. Spironolactone acts on dash. 10 seconds. 2 options. Tell me. Excellent. Collecting that. That's it. Next question. 10 seconds. Thiazide acts where? Again, clinical pharmacology question. Straightforward, right? Thiazide acts on your distal tube. All right. So these are the different things, different drugs. Proximal convoluted tubule, carbonic anhydrase inhibitors can act. Thick ascending limb of loop of Henle, your loop diuretics, where there is sodium potassium 2 chloride transported. Okay, distal convoluted tubule, again CA can act. Thiazide diuretics in the collecting tubule or collecting duct, however you call, there is this potassium sparing diuretics. All right, there is this potassium sparing diuretics. Next question. Dementia patient, okay, with Montreal score of 13 of 20, has a seductive nature towards the neighbors, or he's having hyperphagia, or is he throwing abuses, stripping himself, undressing himself. What is the cause? Disinhibition, excellent, appropriate term, due to the defect of the frontal lobe. It's called your frontotemporal dementia. Next question, middle-aged women with hypothyroidism, previously on thyroxine. She was stable for 2 years. The thyroid function became unstable suddenly. Recently, she has started on HRT for her menopausal symptoms. She has been taking nifedipine for hypertension. So what would have led to this unstable hormone profile? Just look at the stem and think. Just look at the stem and think and tell me what would have led to the unstable thyroid hormone levels. No, I'll give you a clue, Dr. Farina. Drugs she is taking. Any drug would have involved? Come on, think. Any drug. Excellent hormone replacement therapy, OC pills, or anything, hormone replacement therapy, especially estrogen, all can involve in your thyroid hormone. The answer is HRT induced. Okay, the answer is going to be hormone replacement therapy induced thyroid dysfunction. Human bite, not allergic to any drug. The drug to be given is coamoxiclav. Everyone knows. My question is, what are the two organisms comes out and threatens you with human bite? What organism you're likely to be getting? Two organisms. Type in the chat box, all of you. Two organisms. Excellent. Pastorella multifecada, Echinella corrodens. Echinella corrodens, Pastorella multifecada. Pastorella multifecada, right? That's it. Lyme's disease with no history of any drug allergy, obviously you can go for doxycycline. All right, you have to start on doxycycline. Always remember, in Lyme's disease, you don't need to wait till some reports comes. You can start on doxycycline prophylactically. There is nothing wrong with that. A patient presents with palpitation, irregular broad complex tachycardia, then he is cardiovascular. ECG shows short PR and delta wave. You know what is the diagnosis? This is a WPW. What is the most common cause of arrhythmia in a WPW? Anyone? What is the most common cause? It's AVRT. It's AVRT, not AVNERT. It's AVRT. Re-entry phenomenon. Why? Due to the accessory pathway. All right, it's AVRT. This question is wrongly framed. Leave it. APML, acute promyelocytic leukemia. What happens there? Does A happens or does B happens? In acute promyelocytic leukemia, yes. What are the two genes that get fused? Anyone knows, or is it your homework? What are the two genes that get fused? 15, 17, now the chromosome. I am asking which two things fuse together. Excellent, Dr. Anisha Pandey, PMR, RARA. Yes. 70-year-old patient with multiple duodenal ulcer. The question they are asking is now physiology. They are bored of anatomy, they came to physiology. Gastrin acts where for acid secretion. You all know that gastrin goes, it increases the acid secretion. They're asking, where does this gastrin act? Is it A, is it B, or is it C? This is a no it or no it not question. Very simple question. Otherwise, gastrin, acids are secreted by parietal cells. So gastrin has to also act on your parietal cells. The answer is A. Somebody after some road trip, apparently afterwards, features of muscle weakness. Recent URTI, which antibody is involved? Okay, somebody, the respiratory tract infection, upper respiratory tract infection, now has muscle weakness. CSF shows albuminocytologic dissociation. What is it called? Dissociative count between proteins and cells. That's what albuminocytologic. Cytology cell, albumin is a protein. So mostly you will find this in GBS. What antibodies are there in GBS? This is myasthenia gravis. This is not. The answer is A. It's not B. Anti-acetylcholine receptor antibodies associated with myasthenia gravis. Here we are dealing with GPS. Why? Weakness of upper and lower limb muscles. And There is an albuminocytological dissociation. This is a characteristic feature of what? Yes. So the answer is A. Nobody should make any mistake here. Peripheral neuropathy is due to which tuberculous drug? You know what is that? Absolutely, A is the answer. Spot on. 20-year-old girl, okay, has been started on HRECT regime for TB meningitis. What medicine you will add more for up to 12 months in case of a TB meningitis? What medicine you will add more along with the drug she is taking? Excellent, your good old steroids, that is your dexamethasone. All right, good. 30-year-old female with 2 years of rheumatoid arthritis. What future you will find? This is again like, this is a know it or know it not question. If you know it, you will answer. If you don't know it, you can't answer. What is it? Not osteopathy, not joint space narrowing. That's more in favor of osteoarthritis. Classical here, not the periosteal lesion, it's marginal erosions. It's the marginal erosion. Right? Some other time we will discuss on rheumatoid arthritis. Straightforward, all of you have to tell me a diagnosis. Morning stiffness of 60 minutes, a middle-aged mechanic. Rheumatoid factor is normal. Anti-CCP is normal. It was worse with resting. X-ray both hands, wrist shows some swelling and some destructive changes. Long time. They're given the option like this. Somebody told us a rheumatoid arthritis, but it can be something else like that of your osteoarthritis or psoriatic arthritis here. But not rheumatoid arthritis if the anti-CCP is completely normal. I doubt it's a rheumatoid. This question has to be again asked to the people who attended the exam. But regional pain syndrome cannot be the answer. It cannot show arthritic changes. So GBS case, Guillain-Barré syndrome, what will you measure to know the prognosis? Suppose a GBS patient is admitted in your ICU. What will you keep measuring every day? You will measure FVC, force vital capacity. All right, not FEV1 by FVC ratio. FVC is what you are going to measure. Cerebellar stroke, history of diplopia with a huge cerebellar infarct. What structure is compressed? For that, you should know the anatomy, right? Brain pons, midbrain, pons, medulla, and here is a cerebellum. What it will compress? Inspiratory reserve test after FVC, before ventilator or during ventilator, we do. Canal of Monroe, a little bit more. Can you think? What exactly present here? See, cerebellar tumor is there. See, the cerebellar infarct is there. What will be there? What will be present here? I told you this is the cerebellum. This is your midbrain. This is your pons. This is your medulla. What is here? That's my answer. That's my question. What is there? Excellent. That is the fourth ventricle. All right. See here, this is the cerebellum. Okay. This is the cerebellum. This is the fourth ventricle. So if the infarct extends, it will extend into fourth ventricle. Anatomy. Lot of anatomy. I don't know why. Lot of anatomy. Okay. Bitemporal upper quadrant defect. It's due to A, B, or question. Bitemporal upper quadrant defect. Bitemporal upper quadrant defect. Craniopharyngioma compresses from above downwards, so it causes lower quadrant defect. Pituitary adenoma is something that will cause your upper quadrant defect. All right. Straightforward question. Mode of action of lisinopril. All of you know lisinopril is a AC inhibitor. But what does it do with your renin and your aldosterone? What does it do with your renin and your aldosterone? Does it inhibit renin, doctor? It decreases aldosterone. What happens to renin? What happens to renin? What will happen when aldosterone? What will happen when aldosterone is inhibited? This will lead to decreased negative feedback to renin secretion from your JG cells. As a result of that, the renin will increase. But angiotensin-converting enzyme inhibitor inhibits the aldosterone. This will lead to increase in renin and decrease in aldosterone. All right. Clinical pharmacology, little they probed, nothing else. Okay. Little they probed, nothing else. Okay. All of you got it? Okay. Terminal Parkinson's disease patient. Due to disability, he can't take oral medications. He's now having extreme rigidity. His caretaker transfer him to chair, bed. His symptoms are worse, even to rotigotin patches. He was an end-of-life care. Extreme rigidity, end-of-life care patient. Which drug you will give? Parkinson's patient, extreme rigidity. You has come to the end of life scenario. Excellent. Obviously, everyone know you have to go for a continuous infusion of a midazolam. Next question. If you had listened my lectures in the last couple of weeks, you will answer this question. An old man presents with upper GI varices and melena with previous history of 2 times varices now undergo endoscopy found to be having a grade 2 or 3 varices. Adrenaline was given, bleeding stopped with formation of a clot. How do you further manage? What to do next? After giving adrenaline, what to do next? See, this question could have been asked in 2 things. Next, what you will do? How do you prophylactically manage? If they're asking prophylactically or in the long run, you have to go for this. Next, after stopping, you have to give 30%. All right. Because this question, we don't know the full scenario. All these questions we are getting from the candidates and from some other groups. Thanks to some groups, they block us from entering. They're all so secure. All right. So here, if they ask immediately after giving adrenaline, what you will do next? 30%. What do you do to prevent further bleeding? If the question is asked like this, 2 kind of questions are here. I don't understand. If this is the thing, propranolol. If this is the thing, next, then 30%. Always remember. I have clearly told you about upper GI bleed. 8 weeks, leukocytes, nitrates, RBCs are present in the urine. What's the next thing you will give? In a pregnant female, what you will do? A, B, C, D. What you will do? Absolutely, you have to start her on antibiotics. No point in taking culture now. You have to start her on antibiotics. Culture is not going to reveal anything big here. She's a pregnant lady with leukocyte plus, nitrate plus, RBC plus. You have to go for a antibiotics. All right. Antibiotics given in pregnancy especially in UTI, choice of antibiotics. First choice, nitrofurantoin, avoid a term. If estimated GFR is more than 45 ml, it should be. Second choice, your amoxicillin, cephalaxin. All right. This is from your nice guidelines. If you are finding leukocytes, nitrites, and as well as blood or BC, you have to stop, whichever the cause. This question, leave it. That's improperly put up question. 50-year-old alcoholic patient with known case of CLD presented with recurrent hypoglycemia. Again, he developed hypoglycemia. Why there is a hypoglycemia in alcoholic? A, B, C, D, E. Excellent. It's due to glycogen depletion. Female with hypoglycemia, but she's fully alert and conscious. What he will do? Somebody with a hypoglycemia, maybe a type 2 diabetic, she's fully alert and conscious. What is the first thing you used to give? Have you listened to my hypoglycemia lecture? Yes, you have to go ahead for an give her a fruit juice. That's what NICE recommends. NICE recommends orange juice. Fully alert and fully conscious. Fully alert and fully conscious. Orange juice. Give her some drink or give her some drinks like glucosade they use in UK. Glucosade or orange juice. That's what UK recommends. Then comes all your glucose and everything. Okay. This you leave it. This is not fully framed. Yeah. Now this question. Okay. A patient with long-standing type 1 diabetes with myopia and floaters. Diabetic patient with floaters, what you will think of? Floaters are specific for what? Absolutely, it is posterior vitreous detachment. Nasal polyps and sinusitis, recurrent nasal polyps, allergy. Polyps means recurrent allergy, sinusitis. What you will think of? Absolutely, eosinophil. Have to worry about. Kalman syndrome, the feature is, all of you know, do I need to tell? Nasal polyps and allergy, which cell? Eosinophils. Kalman syndrome, you all know, loss of smell. Short stature, but no limb shortening with delayed puberty. What you will think of? Straightforward question. Absolutely yes, Turner syndrome. With exceptional breathlessness was being treated for angina, improved on aspirin and beta blocker. Echo shows normal LV function. Angiography shows calcification. So in a heart failure or an angina, which drug here will increase the survival benefit? Absolutely, AC inhibitors will do. Mechanism of action of baclofen, they themselves are good. GABA B agonist. Okay. Mechanism of action of baclofen is GABA B agonist. Okay. All right, guys. I need another 5 to 10 minutes break. Let us take another 5 to 10 minutes break. Stretch out, relax, reflect. We will be back again. Okay. See you. Hello, doctors. I am back. How many of you are here? Say hi, chat box. We will start another 1.5 hours. We can wind up. Okay, we can now increase the speed, right? We have already taken 2 hours plus another 1.5 hours. We can up the ante. Just wait for 2 minutes. Start. Okay, let's start. It's not about the questions, it's slides. Somebody asked about pregabalin. It acts on voltage gated calcium channels. Okay, pregabalin, not baclofen, pregabalin. It's not about the questions, it's about the slides. We have a lot, but we can cover in 1.5 hours, maybe. Don't worry, sit back and relax. For doctors, please don't ask me this question. I'm sitting here leaving everything to teach you for free. Okay. So, whatever the slides, we will take care. We will teach you. We are here to do that. Okay. After finishing this class, I have 2 paces classes to do. Then I have an RCP meeting at night with some examiners. With all these things, we are giving time and we are teaching you. Why you are worried? Sit back and relax. If you have some work, you guys can take a break, go back and relax. Watch the recording. Okay. That's the best way to learn. A diabetic patient in ulcer on foot, most commonly, you're going to give a co-amoxiclav. All right. That's the drug. It's a common question. Coming to this question, a boy got infection. 2 weeks after that, he developed painless hematuria. 2 weeks after infection. What is the most probable diagnosis? Others? Excellent. The answer is going to be post-streptococcal glomerulonephritis. Okay. So if that is the case, so what exactly you are going to do? Absolutely. Here you have to do a renal biopsy. No excuse. You have to do a renal biopsy, take a nip of the tissue, study it under the microscope, and that's what you have to do. Jamaican patient with spastic paraparesis. You should know the approach to spastic paraparesis. My video is available in YouTube. You can watch. Spastic paraparesis. Due to dash. Jamaican patient. Yes, it is called. What the diagnosis called? It's called TSP, tropical spastic paraparesis. It's due to HTLV, human T cell lymphotropic virus. Who said D? Said D. Who are all sending D? My goodness. Dr. Polio will cause flaccid paralysis. LMN lesion. Spastic is an upper motor neuron lesion. Please, please, please have this very basic, absolutely right. Okay. Polio is a flaccid paralysis that is a lower motor neuron type lesion. HTLV is an upper motor neuron type lesion, spastic paraparesis, where there will be increased tone, increased reflexes. That is upper motor neuron, upgoing plantars. Lower motor neuron, how it will be? Decreased tone, decrease to absent reflexes. That's what you will see in polio. Both are two different entities. All right, be very clear. Achalasia, you know, high resting lower esophageal sphincter. This has been asked in the last diet. They had asked this in the last diet. Coming to this question, systemic sclerosis with CREST findings. A lady comes with odynophagia with solid food. I think they are about to ask odynophagia with solid food, no weight loss. Raynaud's also has Raynaud's and positive anti-centromere antibodies. What is the cause of painful swelling? I don't understand where this thing they are asking about. They're asking about reflex esophagitis, I think, cause of the painful swallowing. Yes, it is due to reflex esophagitis. Okay. Gosserelin mechanism of action, 10 seconds, only 10 seconds. What is Gosserelin? What is the mechanism of action? Only 10 seconds given to you. 10 seconds. Answer. These questions are, I want all of you who are listening to get the full marks and walk. Excellent. The GnRH agonist is an LHRH analog. Sorry, NSAID mechanism of action, another 10 seconds. NSAID's mechanism of action, another 10 seconds. No more than 10 seconds. 10 seconds. NSAIDs, commonly using drugs. Excellent. COX-1 and COX-2 inhibitor. Not a selective COX inhibitor. Selective COX inhibitors are your celecoxib, ectoricoxib. Those are selective COX inhibitors. All right. Human DNA has a wide range to identify pathogens. By what means it does? How? I think the most common answer should be gene rearrangement. All right, now the imprinting gene rearrangement. This we will discuss sometime later in genetics class. All right, ascites treatment, they don't know. I think they are asking about, they would have asked about spontaneous bacterial peritonitis in an ascitic patient. How do you treat? You have to give IV cefotaxime. I think they would have asked about SPP in this section. This could be due. You can treat it with cefotaxime. Docetaxel mechanism of action. So many clinical pharmacology. Left and right, they just bombarded last year with the last paper with clinical pharmacology and anatomy. Docetaxel mechanism of action. 10 seconds, only 10 seconds. Come on, quick. Docetaxel mechanism of action. Excellent microtubule inhibitor. It's a microtubule inhibitors. Microtubule disruption. That's it. Alpha-1 antitrypsin mechanism of action. Complete pharmacology. Clinical pharmacology. Full clinical pharmacology. Yes, to be precise, it inhibits neutrophil elastase. Yes, it's a protease. To be precise, it's neutrophil elastase. All right. Okay. Supraventricular tachycardia patient with Valsalva is failed. And he is also asthmatic. What is the next drug? Obviously, you know, you have to give a in this patient. Last question is the mechanism. Doctor, please listen. Last question, mechanism of action of alpha-1 antitrypsin deficiency. I don't know why you are getting a lag. Everybody is listening and answering here. Is there any issues with your network? Please check it out. Okay, we are giving more than enough time for each and every question and discussing. Alpha-1 antitrypsin deficiency mechanism of action is, you have to find out and type. Neutrophil elastase inhibitor. Okay. Migraine not controlled with sumatriptan or aspirin. What is the next thing you can go for? There are a lot of drugs. They give an answer as propranolol. I think they would have asked for prophylaxis of migraine. I'm not sure of it. It could be the answer. All right. Then the question is what exactly the mutation will be. If there is a family history of breast, ovarian, and carcinoma and osteosarcoma. We all know TP53, right? We have seen in our basic sciences classes. Women presents with bloating, abdominal distension, USG shows left-sided ovarian mass and right-sided effusion. All right. So how to detect? What is the tumor marker for ovarian carcinoma? Ovarian CA. It's CA 125, not 15.3. CA 125. CA 125. All right, don't make any mistake. And also remember, this ovarian carcinomas typically can present with IBS-like syndrome. What is IBS? Irritable bowel syndrome-like syndrome. Other condition that can present with IBS-like syndrome is your giardiasis. It again presents with IBS-like syndrome. Patient with 2 episodes of amaurosis fugax in 3 months. Carotid obstruction is about 50%. What is the drug you will prescribe? Somebody with amaurosis fugax coming to you, he's sitting right in front of you, you did a carotid Doppler, and the thing is, next thing is you have to go for an aspirin. All right, aspirin. Patient with cocaine overdose with severe chest pain. You all know this is a coronary vasospasm due to cocaine. Okay, this is a coronary vasospasm due to cocaine, not atherosclerotic vasospasm. So you have to give a nitrate or later calcium channel block. Patient with irregular complex tachycardia, they had asked, this is a wrong question. We don't know what is it. It's not full. Okay, not benzocaine, benzodiazepine. Yes, you can give, but pertaining to arrhythmia, okay, pertaining to arrhythmia, you can give a nitrate. Pertaining to arrhythmia, you can give a nitrate. All right, or a calcium channel blocker. Benzodiazepine you give typically to make the patient relaxed more and make the patient to just like calm down. For that you have to give. Okay, most people with this stuff will come very agitated. All right, patient talking treated with clarithromycin rise to CK plus, for example, hematuria. Not stations, statins. Patient taking statins, clarithromycin rise to CK plus hematuria. Diagnosis is statins, clarithromycin rise to CK hematuria. What is the diagnosis? Rhabdomyolysis. It's called rhabdomyolysis. How do you treat rhabdomyolysis? IV fluids plus soda bicarb to prevent the acid load on the kidneys. To prevent the acid load on kidneys. Patient with oliguria, fluid resuscitation of choice. What will you give? Oliguria, fluid resuscitation of choice. Excellent. Hotman solution. Spot on. Who said it? Dr. Dakshini. Yes, Hotman. Yes, Dr. Harim. That's a Hotman solution. No NS, dextrose, NS, KCL, no, nothing. You have to put the patient on Hotman solution. Looks like those people to whoever answered spot on has critical care ICU experience. Okay, Hotman solution. Please beware. Now, acute medicine is most wanted field in UK. Okay, so all of you should have some experience in acute medicine because it doesn't matter whatever you do. See, for example, myself, now I'm a prospective stroke medicine resident. Stroke medicine people itself, they are asking to do 6 months. All are posted in acute medicine. 6 months is geriatrics. So acute medicine is going to be a part and parcel of you. It doesn't matter whichever specialty. If you are going to take a group A, you will be posted there. So you should be thorough with acute medicine management. And most NHS interviews, they are asking some scenarios from acute medicine. So beware, this immediate management of AKI, immediate management, all these things, learn here itself. There is no point in sitting and reading this 10 days before interview, 1 week before interview, and then scratching our head. Okay. Patient was on dapsone with normal PO2, low SPO2. You know, this discrepancy is seen in methemoglobinemia. Sulfonamides, dapsones, all these drugs can cause methemoglobinemia. And also methemoglobinemia is one of the causes of your cyclical cyanosis. The cyclical cyanosis occurs due to methemoglobinemia. Patient was on bisphosphonate presented with swelling over the jaw. What is the adverse effect of bisphosphonate that cause swelling over the jaw? Anybody know what is it? Excellent. Osteonecrosis of the jaw. Osteonecrosis of the jaw. That's the answer. Osteonecrosis of the jaw. Redness of conjunctiva, hypophaeon, lens usage, and red painful eyes. That's it. Straightforward question needs a straightforward answer. What is it? In a lens user, hypophaeon, it's a keratitis. Mostly it would be a fungal keratitis, right? Or it can, there is a satellite lesion, you can think of chest. They said pseudomonas, it's nothing specific unless and otherwise mentioned, it's a keratitis. Nicorandil helps with angina by dash. Last week we have discussed this in our free lecture. Last week we have discussed this in our free lecture. And whoever attended, I had told clearly how this drug actually functions, how this drug helps with angina, how does it functions. Everything I had clearly explained. It causes direct coronary dilatation. It has an action on nitric oxide and causes coronary vasodilatation. All right, then comes reduction of preload and afterload. The angina is relieved by coronary dilatation. Okay, angina is relieved by coronary dilatation. All right, chest pain, right JVP, heart rate 60, ankle edema, tachypnea. What could be the positive artery? Okay, I'll tell he may be also having vomiting or nausea. What MI is this? What MI will produce with the bradycardia? You know, tachypnea, anything, vomiting and nausea and all. Inferior wall MI. Inferior wall MI. Okay. It has a vagotonic action. That's the reason they'll have nausea, vomiting, and bradycardia. See heart rate, bradycardia. This is due to RCA. Excellent. This is due to right coronary artery. It's an inferior wall MI. I hope all of you got it right. This is an inferior wall MI. Next question. Death of a wife 9 months ago, and after the death of the wife, the person is getting flashbacks and hallucination. I told you if somebody is getting a flashbacks and hallucination post-traumatic event, there is only one diagnosis. Flashbacks and hallucination post at some terrible traumatic events. That is, no, not bereavement. I clearly told what is that. Post-traumatic event, somebody got raped or somebody got assaulted, and again when the person comes back home, the same thing replays in the mind and the same things keeps on getting flashback. That is your post-traumatic stress disorder. Trichomonas vaginalis, what is the treatment? Straightforward PHC level question. Trichomonas vaginalis, what is the treatment? Of course it's metronidazole. All right. The treatment is going to be your metronidazole. Patient referred for screening of hemochromatosis. What is the most appropriate treatment for hemochromatosis? Most appropriate treatment, deferoxetine, viroxamine observation you can do, but the most appropriate treatment is going to be the appropriate word. See, here is venesection. Appropriate word is section. TIPS complication. We had a PACES communication scenario on TIPS. And the examiners calibrated it in a way that unless and otherwise candidate address this particular complication of the TIPS, he will not be given pass. What is that? Excellent, because it's bypassing the ammonia and the metabolic waste products will be building up here and it will lead to hepatic encephalopathy, one of the dreaded complication of the TIPS. Sjogren's syndrome patient present with dry eyes. What is the most common ophthalmological features of Sjogren's syndrome? Straightforward question. Straightforward question. What is the most common? Excellent. Yes. Keratoconjunctivitis sicca. Absolutely spot on. It is keratoconjunctivitis sicca. Patient with nodule on eyelid close, lateral canthus. Okay, this is some kind of nodule present in the eyelid. What is the most common organism? Any idea? Typically Staph aureus. Typically Staph aureus. Like that, if somebody is having a pimple or a bump inside the nose, mostly Staph aureus. So you give mupirocin ointment to staph clearance. Patient with seborrheic dermatitis. What is the next thing you will suspect? Two conditions, 1 and 2, I want you to tell. One is HIV, obviously, immunosuppression. Next, seborrheic dermatitis. Excellent. Yes. Dr. Sonia Zafar. Absolutely. Parkinson's disease. Good. Patient with bloating, weight loss, diarrhea, low IgA, villus atrophy. Straightforward. You don't need to think a lot to answer this question. This is a case of a celiac disease. Absolutely. Elderly patient with 20 smoke years of alcohol and smoking, weakness in all four limbs with hyporeflexia, plus it improved with restrainment. What is the diagnosis and the underlying diagnosis? Patient with weakness but repeated exercise, that is called restrainment or recruitment phenomenon, is repeatedly moving the limbs, is improved the weakness. What is the diagnosis? Absolutely, LEMS. Fine. Okay. Somebody with a 20 years of smoking history with LEMS, what would be the underlying diagnosis? Somebody with a 20, excellent, lung cancer, small cell lung carcinoma. It's a paraneoplastic syndrome, right? Paraneoplastic syndrome. Now, Barthel index is for what? I had told you in my stroke lecture. What is called PROM? Patient-related outcome measures. This was asked by the people in neurology station 3 in PACES. Only one person answered. He's a neurologist, actually. He answered that. PROM. Those are Barthel index, Rankin index. This is for activities of daily living of the patient post-stroke. Right? Somebody with ascites, the answer they expected is ascitic fluid analysis. All right? Ascitic fluid analysis is what you're going to do. Dermatitis herpetiformis, what you will find deposited on the skin biopsy? Straightforward question. Dermatitis herpetiformis patient, what exactly you will find deposited? Excellent. Yes, IgA. No follicular keratinosis, nothing. It's simple IgA deposition. That's what they are asking from you. Patient of ulcerative colitis presented with 6 bloody stools per day. After 3 days of treatment, steroids, everything, hemoglobin is 12, WCC is 13, CRP is 60, albumin 32, low. What biomarkers will indicate the patient needs a surgery? They went up to F. Which of the following will think the patient will need a surgery? Number of stools is not there. Hemoglobin anemia, you can count if it is more, but anemia is least around 12. CRP levels is another thing you can consider. We don't know the real option. These things are immaterial, but anemia, that is the hemoglobin level. I don't know why they brought it as F. Fecal calprotectin is a marker. It doesn't call, says you should go for a surgery or not. CRP levels and anemia, that is HB levels that you can think of. Cancer patient with sudden urinary retention and loss of sensation in the lower limb, what you will think of? Obviously, MRI to see a metastasis, right? MRI to see a metastasis is what you have to do. This is something we have discussed. MHC, they had asked, MHC class 2 binds to what? MHC class 1 binds to what? CD4 and CD8. All of you should. Okay. Somebody presenting with anaphylaxis, that is latex allergy. Which of the fruit is notorious to cause that? Which of the following is notorious to cause that? You may be thinking peanut, but the answer will be a little surprising for you. It's not the peanut. The answer here is your banana. Increased predisposition to latex allergy. Of course, because we all go for a peanut, because we all know something very common, nut allergy. This gentleman has nut allergy. He is allergic to nuts. She is allergic to nuts. Nut, and nuts. But it's the banana. Okay. Which of the following they had asked? Highest risk of contamination. Remember, platelet transfusion has the highest risk of contamination. Okay. Platelet transmission has the highest risk of contamination. Just to remember that. All right. Platelet transmission, highest risk of contamination. ARDS. Pregnancy-related ARDS is due to A, B, and C. Which of the following is the most likely cause for a pregnancy-induced ARDS? Pregnancy-induced ARDS. Excellent. It's due to increased permeability of the alveolar capillary membrane. The answer is C. 10 seconds. Bevacizumab. Mechanism of action. 10 seconds. 10 seconds. Excellent. It's a vascular growth, endothelial growth factor inhibitor. Mechanism of action of paclitaxel. They rolled people on pharmacology last time. They just rolled. They just submerged people with clinical pharmacology. They didn't spare anyone. They didn't spare anyone from clinical pharmacology. That's why I hope all of you would have listened to my lectures so many times. I would have begged people, read clinical pharmacology, read clinical pharmacology. That will determine your pass or fail in your MRCP examination. That's why for the next batch, a specialist tutor is coming. Mechanism of action of paclitaxel is what? Why nobody is answering? Went to Google, it's fine, still answer. One person has answered. What about others? Why there is a silence? Other people, come on. Yes, microtubule stabilizer. Okay, so microtubule stabilizer. That is, it prevents the depolymerization of the microtubules. Coming to mechanism of action of clopidogrel. Please don't disappoint me. This is a very common drug. You should tell me the answer. Very common drug. There is no excuse to forget this point. No excuse whatsoever. What? CYP2, no, it inhibits ADP receptors. P2Y12. Inhibits ADP receptors. What causes creatinine rise in patients who are taking Bactrim? Bactrim is what? Trimethoprim sulfamethoxazole. So, what does this drug that leads to increased creatinine in the serum? Any idea? The answer is B. It competitively inhibits. This is the proximal convoluted tubule. Okay. Suppose if creatinine is going here, it will go all the way into the urine. But this drug comes and inhibits this. As a result, creatinine will be more in the bloodstream. As a result of that, what will happen? Creatinine level will soar up high. Women's aunt got diagnosed with Crohn's disease. She has been having intermittent abdominal pain, diarrhea, bloating for several months. Lab shows anemia, and CRP is find anti-TTG negative. What is the next thing you will do for a Crohn's disease? What is the next thing you will do for a Crohn's disease? What is the next thing you will do for a Crohn's disease? Anyone? What is the next thing you will do for a Crohn's disease? Absolutely. Colonoscopy plus biopsy. It's colonoscopy plus biopsy. Fetal calprotectin is a marker. You are not going to do anything. You admit the patient, go for a colonoscopy. How come hypertrophic obstructive cardiomyopathy is associated with the increased risk of sudden cardiac death due to dash? No, this is a component. Just because septum thicken, nobody will die. Not just because of outflow gradient. Have you heard of something called SAM? What is SAM? Systolic anterior motion of the anterior mitral leaflet. This is the thing that leads to obstruction and sudden cardiac death in outcome. That is why you call it as hypertrophic obstructive cardiomyopathy, not just a hypertrophic cardiomyopathy. It's due to SAM. Watch our echo lectures. Our cardiologist, Dr. Haynes, has beautifully explained this phenomenon. And how it leads to cardiac arrest is explained with the echo video. You shouldn't miss it. Okay. Which of the following will increase a further cause of TIA? ABC? Any idea? Excellent. A previous TIA can cause a further TIA. Or a TIA could be a stroke in evolution also. All right. This question is not done. Here is the question we need to go for. Yes. Not dementia. Lewy body dementia. What is the characteristic features of a Lewy body dementia? No, Lewy body dementia, they will have hallucinations. They are very sensitive to neuroleptics. Okay, they are very sensitive to neuroleptics, and that is the answer. That is the answer. Okay. Meningitis, blood culture of listeria is there. Listeria is there. So you started on IV ceftriaxone. What other antibiotics you will add? You always should know ampicillin and gentamicin are the two other antibiotics you will add for a patient with listeria. Ampicillin and gentamicin are the two other antibiotics are the ones you will add for a patient with listeria. Coming here, decreased sensation over the thumb and index finger. Which nerve root is involved? Just tell me this. And diminished biceps. Thumb and your index finger. Which nerve root? And also your biceps. Gone. Not C5. C5 doesn't come to your thumb and index finger. What does comes to your thumb and index finger is C6. C6 if this is your hand. This is the thumb, index, middle. This is your C6, C7, C8, T1. All right? Not C7, it's C6. Thumb and index finger, C6. C7 is your middle finger. C7 is your middle finger. Okay. Weakness of dorsiflexion and eversion. What nerve supplies the muscles of dorsiflexion and eversion? Straightforward anatomy question. Which supplies? Peroneal nerve. Common peroneal nerve. It is your common peroneal nerve. How do you differentiate common peroneal nerve? Common peroneal nerve palsy with the L5 radiculopathy is something I want all of you to study. Here inversion will also be gone. Here it won't be gone. Other things you have to study. Okay, that's your homework for the day. Cranial F7 palsy with loss of taste, difficulty chewing and swallowing, and hearing issues are also there. Where could be the lesion? Absolutely yes, facial canal. It's the facial canal, not on the stylomastoid foramen. Okay, I will teach localization of lesions of facial nerve some other day. There is a table. Okay, right now we don't have time for that. I will teach you. When the facial canal is affected, there will be difficulty chewing and swallowing because masticatory muscles also will be affected. Okay, so how do you test a facial nerve? Go ahead, ask the patient to raise the eyebrows, close the eyes tight, grin the teeth, blow the cheeks. Why? Facial canal issues are there, then hearing issues will be also there. Difficulty chewing and swallowing and loss of taste sensation will be there. Why? Chorda tympani nerve. Extremely important. You should know how to trace the facial nerve, anatomy of facial nerve. Extremely important. I'll try to teach for a day. Okay. A patient with myelodysplastic syndrome just received RBC transfusion. Suddenly he develops shortness of breath, bibasal Krebs, JVP is up. What is the diagnosis? You are giving an RBC transfusion. Suddenly he is developing all these things. So much of confusion, I'll tell you. Just listen to me here. Shortness of breath, increased JVP, repetitions equal to dash or a acute overload. And along with that, there is a systolic BP of 150. Acute pulmonary edema or acute circulatory overload. Okay, so the answer is B. Transfusion associated circulatory overload. All of you got it? This failure is due to circulatory overload. That's why you're getting shortness of breath, increased JVP, crepitations, and increased systolic blood pressure. Increased systolic blood pressure. 50-year-old man with evidence of acute left-sided stroke has anemia, thrombocytopenia, and raised LDH, normal coagulation. Okay, and fragmented RBC. What is the diagnosis? Which thrombocytopenia is associated with CNS defect, like that of a stroke? Excellent. Its answer is A, TTP. This person you leave. Tuberous sclerosis, renal manifestation is angiomyolipoma, that you all should know. Man with new thyroid nodule. Thyroid nodule evaluation, extremely important. Newly diagnosed thyroid nodule. Which thyroid cancer will you will think in terms of a MEN2 syndrome? MEN2 syndrome, the thyroid cancer you will be thinking is in terms of a medullary thyroid carcinoma, right? All of you. Women with 3 months post-delivery having unilateral exophthalmos, goiter, heat intolerance, low TSH, rise T3 and T4. Diagnosis? Absolutely, this is straightforward. Graves' disease. Patient with type 2 diabetes now presenting with ischemic optic neuropathy. What is the next thing you will do with altitudinal defect? With altitudinal eye defect. Absolutely. You have to go for a carotid duplex. You have to check any carotid artery stenosis, thrombosis, or an embolus, something traveling through carotids. You have to do a carotid duplex. Okay. Malnourished man with red crusted lesion. Which deficiency will give rise to a red crusted lesion in a malnourished gentleman? In a malnourished man, a red crusted lesion is seen in dash. Excellent. Zinc deficiency into acrodermatitis enteropathy. Okay. I just need another 5-10 minutes gap and break. Then we will start. Please be here. We will work out for another 25 minutes and then wind up. Okay. Just give me 5 to 10 minutes. Then we'll work out for another 25 minutes and wind up. Okay. See you guys. Hello, doctors. I'm back. We'll do a quick 15-20 minutes recalls and wind up. Anybody is here? All of you are here. Hello. How many of you are here? Attendance is going down after 3 hours. Good. Yes, yes, yes. Welcome, welcome. I'm back. We can begin. I know it's a long lecture. Continuously staying up here for 4 hours, 3.5 hours can be really hectic. It's fine. Still, we are called to study. Okay. Come on, quickly. Women ate oysters, tuna, mussels, and wine, and suddenly flushing. And what's the diagnosis? Shellfish poisoning, right? Not mercury poisoning. Mercury poisoning is entirely different. This is shellfish poisoning. Doctors, mercury poisoning is not something you will get within 4 hours. Okay. Mercury poisoning is a chronic thing. It will take ages, it will take a while for you to get that. This is something due to shellfish. Shellfish are what? Your oysters. What toxins are there in such things? Mussels, oysters, tuna, and all. Any idea? It's scrombotoxin, scromboid poisoning, not botulinum. How botulism presents, doctor? Botulism presents as a dissenting paralysis. It starts affecting with your eyes, then difficulty swallowing, bulbar weakness, not with vomiting and loss of vision immediately within 4 hours. This is a scrombotoxin poisoning. Answer is yay. Mercury poisoning is a chronic condition which leads to neuropathy and all the findings. Okay. Next question. This you leave it. Yeah. This you leave it. A patient who is an alcoholic presents with confusion, ataxia, white-based gait. They're asking about Wernicke's. What is the next thing you will find? What is the next thing you are likely to find in a Wernicke's? Excellent. You will likely to find ophthalmoplegia. You are likely to find ophthalmoplegia. Somebody with a depression, fluoxetine is not helping. What is the next drug you will add? We have discussed this in our psychiatric classes. What is the next drug you will add if fluoxetine is not helpful? What is the next drug you will add? What is the next drug you will switch to? Up to 6 months he has been treated. You have to go for venlafaxine, not phenylism. We are not using that. You have to go for venlafaxine. I told you the order of escalation for depression in psychiatry lecture. You have to go for venlafaxine. Somebody on chemotherapy for AML, but patient has very high fever and high WBC count. What could be the causative agent? High WBC and AML patient on chemo. Antibiotics have been given. So antibiotics would have, the bacterial infections would have controlled. But viral infections cannot be. The answer is yes. CMV is the most likely cause in a case of a post-chemo fever who is already on a broad spectrum antibiotics. Post-stroke patient can't even get into the chair. In winter, he got hypothermia, therefore taken to the hospital. How can he maintain his body temperature? Old person, he got hypothermia, and how he can maintain? I'm not sure. They're telling loss of behavioral adaptation. This question I'll refer and leave it. Patient on antipsychotics. Okay, patient on antipsychotics, another medication, presenting with stroke. Which of the following is the culprit agent? Thrombogenic antipsychotic, or the antipsychotic that would have caused insulin resistance and everything leading to stroke? Excellent. The answer is A, clozapine. A patient with history of acanthosis nigricans, high BMI, likely diagnosis is A, B, or C? Most common, diabetes. Most common is diabetes. Most common is diabetes. Then comes hypothyroidism. Most common route for MCA thrombectomy, middle cerebral artery thrombectomy, through which pathway you will reach? Again, anatomy. To do a middle cerebral artery thrombectomy, which pathway you will reach through? Excellent. You have to go through left common carotid route. That's what we do in interventional neurology. You have to go through the left common carotid route. A patient with bipolar disorder is on lithium. He's recently started on diclofenac, that's NSAIDs, and he got confusion. What is the reason for the confusion? A patient on lithium suddenly started on diclofenac as well. Now he's undergoing a confusion. No, not hyponatremia. Here clearly two drugs have been given. So they are trying to implicate something about the drugs here. Again, clinical pharmacology, left and right, last paper, clinical pharmacology. They just destroyed people. Lithium toxicity. It is lithium toxicity. Go for 176 right away. Here in the 176th question, they are asking about a patient with a history of sickle cell anemia. With anemia, decreased hemoglobin, low retic count, splenomegaly, WBC is high. What is it called? Straightforward question. Splenomegaly. Listen carefully. Splenomegaly, low retic count, decreased hemoglobin. Splenomegaly, low retic count, decreased hemoglobin, WBC is high. Straightforward. This is a sequestration crisis. Okay. There are aplastic crisis, hemolytic crisis, sequestration crisis. Please read about that. Know the difference between all these three. It's a very frequent question. All right. Very frequent question. Next is a common sense question. If you all we possess common sense, what happens? Somebody eats a high glycemic index food. Somebody eats a baklava. What happens? Of course, rapid rise in the postprandial blood sugar. Okay, past medicine. Please don't follow past medicine. Most likely to follow other things. Like if you have a doubt on that, refer some Oxford textbook or handbook of medicine. That will help. Okay, I will also check and I'll try to post a difference between all these three crises. Secondly, these questions are kind of like, not straight away we are getting from any source like pastors or anything. We are just getting through word of mouth. Some candidate went, he attended something and he came and he is telling us. All right. That's how it is. There was a patient with facial flushing and other features of SLE with scarring hair loss. What is it called? SLE features with a scarring alopecia, right? Scarring alopecia. SLE will cause scarring or non-scarring alopecia. SLE in itself will cause non-scarring alopecia. But XLE patient, SLE-like feature patient with a scarring hair loss is nothing other than your discoid lupus erythematosus. All of you got it? Excellent. It is a discoid lupus erythematosus. Patient with well-demarcated hair loss with hair follicles were visible. Or maybe I will add one more point, exclamation hair. Exclamation mark hair. What is it? Straightforward, it's your alopecia areata. Very good. 22-year-old female with multiple attacks of loss of consciousness. Recently, she has been regarding separation of parenthery. During the attack, she freezes up to 20 minutes and she comes back to normal. She has some episode which she stares at the same thing and her impaired awareness. Then she comes back to normal. In a 20-year-old, what do you call it as? What seizure? This is not happen seizure. What is CPS? Not pseudo seizure. It's a complex partial seizure. Absent seizure won't go for such a long time. Absent seizure, you'll talk to me 3 seconds, I'll be back. This is a complex partial. No, it's not conversion disorder at all. Nothing says that. Okay. So complex partial seizure. 20 to 20 minutes of loss of consciousness, I mean, like loss of attention, and then she'll be back to normal. She freezes, back to normal. It's a classical complex partial seizures. All right. Man with previous tumor has been resected and sudden onset bilateral weakness after tumor resection with incontinence. Okay. Weakness and numbness up to, I don't know, with the relative sparing of proprioception. What they are telling, weakness and numbness and sparing of proprioceptions means the spinal cord is there, the posterior part of the spinal cord, the dorsal column is spared, but the anterolateral column is affected. So how it can happen? A, B, C, D. Which of the following will cause a dorsal column sparing and only affect the anterolateral column? Is your anterior spinal artery? In fact, all of you got it? It's an anterior spinal artery. In fact, okay. 183, let's go. There is a history of PCI, percutaneous coronary intervention. After that, they followed by that, there is a rash and purple toes and elevated creatinine. What is it called? Straightforward. Post PCI, somebody is having purple toes, developed a rash and elevated creatinine. Excellent. It's a fat or also cholesterol emboli. It is a cholesterol emboli. Fat embolism is something that you can expect after fracture. Of course, cholesterol is a type of fat. It's a cholesterol emboli characteristically. All right. An old dude refusing to go out, refusing to his grandkids to visit him, losing focus, staying at home with memory loss. What could be the cause? Not agoraphobia, not delusional. It could be depression, also paranoia, but there is nothing suggestive of that. A depression or a paranoid depression with the answer here. All right. A patient presented with confusion and QTC is prolonged. What is the next thing? What is the thing you would consider in a psychiatric patient? In a psychiatric patient with QT prolongation and confusion, what will you consider? Excellent. TCA overdose. So what is the next line of treatment here? Yes, absolutely. IV soda bicarb is the next line of treatment here. A patient here is with hepatomegaly. X-ray shows loss of joint space and chondrocalcinosis. What is the diagnosis? Loss of joint space and chondrocalcinosis. Straightforward diagnosis. It is your good old hemochromatosis, right? Next question. Patient 70 plus with this joint replacement surgery is on due and pre-op investigation shows normal platelet, normal PT, increase APTT, and there is a bleeding during dental procedure, ABC. Which one is the right answer? Absolutely yes. The answer here is the good old hemophilia. This one. A patient present with dysphagia, dysarthria, ipsilateral abducens nerve palsy, that is sixth cranial nerve, and ipsilateral facial nerve palsy, that is seventh cranial nerve. Acquired and inherited hemophilia, I have to refer and tell you, doctor. That is hematology department. I'll refer and post in the group. Okay. And there is contralateral spastic hemiparesis and contralateral loss of fine touch vibration and proprioception and lateral gaze palsy. Which place will you localize all these things to? Absolutely correct. Is it a medial pons or is it a lateral pons? Is it a medial pons or is it a lateral pons? Absolutely, it's a medial pontine syndrome. Here, this is something they're asking unilateral DIP and MCP involvement. DIP involvement, dactylitis, mostly it is going to be your psoriatic arthritis. Simple question, that's why I ignored. 55-year-old man with a history of sensory neural deafness presents with the pain in the left leg and pelvis. Calcium is high, ALP is very, very high, vitamin D is reduced, PTH is very high. What is the thing you will do in this case? Pain in left leg and pelvis could be a fracture. So what will you do? What will you do? Absolutely, you have to do a parathyroidectomy. Parathyroid hormone has to be removed. Gland has to be removed. All right, not bisphosphonates. What happened? He's already having fracture, sensory neural deafness. You have to go for removal of the gland. This question is wrong. This is something randomly they ask most contagious infection in the hospital. Which infection here could be most contagious? Any idea? No, the answer here is varicella. Varicella is more contagious than other organism. Varicella. Thrombolysis indication in a pulmonary embolism. When you will do among the following? Excellent. If there is a persistent hypotension, you have to lyse the thrombus. There is no excuse, nothing else you will do. Yes, this one. ABG shows HAGMA, high anion gap metabolic acidosis. So in case of a HAGMA with a normal glucose, just 1 plus ketone, what will be the diagnosis? Absolutely, yes, it's ethylene glycol toxicity, not lactic acidosis. DKA glucose cannot be normal. Even suppose a euglycemic decay, but it will not produce acidosis to this extent. Okay, the answer is B, ethylene glycol toxicity. Diabetic ketoacidosis is not the answer because glucose is absolutely not. It is in smoking history and retinopathy. It was progressive in nature. What is the most important thing you will stop? Because you know always a microvascular complication, one area you find, you have to look for other microvascular complication also in case of a diabetes. So retinopathy is there means he may be having a nephropathy also. So what is the one thing you will do to stop his renal progression? Of course, the next important thing is smoking cessation, but the most important thing that will prevent the renal progression is a glycemic control. Then comes your hypertension, insulin, stop smoking, all are next thing. But the glycemic control, very strict glycemic control, maintenance of HbA1c in the level of 5 to 6, he will be fine. All right, he'll be fine. Last question, where does vitamin D gets activated? Straightforward. Vitamin D gets activated in ABC. Oh no, where it's get activated? Not in the skin. Absolutely, vitamin D gets activated in your kidneys. All right, vitamin D gets activated in your kidneys. There is no doubt in that, right? Vitamin D gets activated in your kidneys. Okay, thank you so much, everyone. We have come to the end of the session. And thank you, everyone, for tuning in and listening to us. Okay, And please, the take-home message is, please be aware of clinical form and basic sciences. A lot of MCQs. Thank you. Thank you, everyone. You guys are most welcome. We'll have some free sessions till October 6th. I'm a bit held up, and after that, I can conduct free sessions for you all and wish you all the very best. If you guys need any kind of preparation, last minute, I would suggest you to go ahead and go through what you have already know. And the next step would be work out the past papers in exam settings. All right, in exam settings. Just people with few days before the exams, 2 weeks before the exams, please revise past papers, revise past papers, revise past papers, and do nothing. That's my suggestion. Okay. Anatomy, how much you need? A little bit of anatomy is need. We are working out. We are just trying to formulate what exactly, how much anatomy people are needed actually for people needed, how much anatomy is needed for the people for MRCP part 1. We are just formulating plans so that we can actually pull in an anatomist. Okay. How many past papers depends on the time, doctor. I would suggest last 3 years. Last 3 years past papers is quintessential. And if you have time, I would best suggest last 5 years part paper. Okay. Past papers. Okay. All of you, thank you so much. Thank you, everyone. Any doubt, please let us know. We are more than happy to help you. And please leave some feedbacks in the group you are coming from. That is the one thing you are doing for us. And we are doing it for you for free. Just leave your feedbacks. It doesn't matter whichever group you are coming from. Please leave your feedbacks. I'll see you again with free sessions in after October 6th. I am off till October 6th. I hope all of you know we have an offline program in India, in Tamil Nadu, in Tiruchirappalli on 6th of October. Okay. Session notifications will be given by the moderators. Okay. We have an offline program. Anybody in and around India, please, you are welcome. That's for MRCP part 1 and 2 and basis. You can witness and meet up with the Royal College people. Our Royal College President of India, Lead of India, he is coming, and a lot of excellent doctors and examiners are coming. It's a free program, free lunch. We are more than happy to help you. You guys are most welcome. It's done by MedExam Expert in association with Diabetes Club of Trichy and as well as API, Association of Physicians of India. Telecast, we will broadcast after the program gets over. We'll record and play. Thank you, everyone. And please leave your feedbacks. Have a great day, great night, great morning, afternoon, where you are from. Good night. Bye-bye. See you. God bless you all.